Okay, so I wanted to talk a little bit about drug testing. I was asked to talk a little bit about this. I participated in writing a white paper with ASAM about drug testing. There's a lot of misunderstanding. So I wanted to talk about the different matrices, the different things you can test for, the basics of drug testing, what to test, how to test, and in what situations to perform a drug screen, and then really interpretation. And we'll talk about that very briefly. Again, in 15 minutes, this is like a 3-hour topic, so I'm going to really go faster. What to test? You can really test any tissues now. We tend to focus primarily on urine because it's non-invasive and widely available. Obviously, one of the questions I always get is, what do you do with a patient who can't pee? For example, a patient with end-stage kidney disease on dialysis. The next best test is actually oral fluid, then, salivary for those patients. I would avoid blood unless you're doing blood alcohol levels or volatile chemicals such as methanol, things like that. Really, blood testing is a thing of the past, and I'll show you why. So when you look at this graph, this is a concentration on the y-axis, and this is time on the x-axis. Interestingly, and the reason we like urine is it's right in the middle. So blood, you won't capture many things after a few minutes. Heroin, you may capture for about 30 minutes before it is diffused into tissue. Many of the fat-soluble substances won't be in blood for very long. Oral fluid also has a very, very fast peak, but it does stay in the system for a little longer. So salivary, you will miss things. If you test at 1 or 2 days later, you may miss use. Urine tends to have the highest peak as far as concentration in a body fluid, and it has the longest duration. So the concentration to time is what we look at. So the urine is probably the optimal testing matrix as far as drug testing. Once you get to sweat and hair, sweat, Department of Correction uses, sometimes hair and nail samples, Department of Correction uses. For clinical practice, these are really not that useful. Department of Corrections in our area does use sweat sometimes. They use sweat patches because they stay on for 24 to 72 hours. And it does tend to deter use during the time the patch is on. The patches, when they go on, if you pull them off, you can tell because they're tamper resistant. So when you pull them off, they change color. They're hard to put back on, things like that. But we don't use that in clinical practice. So urine is what you're going to primarily see. How to test, I get these questions often, scheduled versus random. If you ever see this on an exam, because it's shown up on our internal medicine boards, random urine drug testing is the preferred modality in addiction and pain management options. But in clinical practice, it can be technically challenging to perform a true randomized test. And I could get into detail about that. But the bottom line is that is the gold standard. But in clinical practice, we use a lot of what I call pseudo-randomization procedures to try to really do the best we can with what we have. Random drug testing decreases the risk of subversion, particularly in urine drug tests, and increases the risk and increases detection of unwanted substances. Forensic versus clinical drug testing. In a forensic drug test, that is a legal drug test. Essentially, the difference between the two is chain of custody. So with forensic drug tests, every part of the collection and transport and testing is monitored. So from the time the patient pees in the cup, which is monitored, to the time it gets to the testing, everything is safeguarded so that we know that that sample is definitely the patient's. This was the issue in the Ryan Braun case that made big news several years ago, is that was a forensic drug test and chain of custody was not maintained. Clinical drug testing is the same as any other clinical study we do. The goal is it's basically the clinical standards apply. So whatever we would normally do for any other test, we would do for clinical. We do not need to monitor patients, and we don't need to maintain chain of custody, which means that theoretically it should not be used in a court of law, although we know that sometimes it does. But these drug tests are not considered forensic, and we are not required to do those in clinical testing unless you work in an employer setting or some other setting which would require forensic drug testing, like a drug court. Confirmatory testing, when is it necessary? In confirmatory testing, we're talking about the GCMS or LCMS-MS. This is what I call identifying the drug. So when you see an opiate positive, how do I know what that opiate is? That's a confirmation test. Confirmation tests should really be performed on all positive immunoassays to rule out false positive findings. In a clinical situation where a positive test will change the treatment plan, so in someone who's saying adamantly, I am not, who's on Suboxone, for example, and is saying I'm not using benzodiazepines, that's not true. I really want to, that's a situation where a positive immunoassay result might change the treatment plan. It may cause some concern to the provider about continuing to provide Suboxone in someone who's using benzodiazepines, when in fact that benzodiazepine screen may be a false positive. And by the way, this patient we just discussed is on one of the highest offenders for false positive, sertraline. Sertraline has a fairly high false positive rate on the benzodiazepine immunoassay. So patients on sertraline may test positive for benzodiazepines even though they're not taking them. What should we test for? Really, anything that's commonly prescribed in the area where you're working or commonly abused should be looked for on the drug test. So in the old days, we had what they called the SAMHSA-5, which was the most common drugs that the Department of Transportation really wanted to test for. Turns out many of those drugs are not the worst offenders now. Oxycodone, for example, isn't captured on that. So your drug test should really be tailored to regional variances in drug use. In my neck of the woods, methamphetamine is not as common as it is in the north and west of Wisconsin. So we don't routinely test for methamphetamine like they should be in northern and western Wisconsin. Quantitative versus qualitative. Again, quantitation is not typically necessary in most clinical settings. There's a few exceptions to that. For example, marijuana, getting a THC to creatinine ratio, which is a THC that is standardized for creatinine, is sometimes important to know if they're actually decreasing use. Testing depends on the clinical situation. In addiction care, what I do and what Dr. Batnagar does, obviously we will probably test more often because our patients are there for treatment and we have to monitor their progress in treatment. Emergency department, it's typically for evaluation of overdose or altered mental status or sometimes for medical clearance. Alcohol levels tend to be more commonplace in the emergency department. And then there's pain management in primary care. This is a big new, not new, but relatively new utilization for drug tests. And it really, there's a lot of concern about how often to test. And you can really assess risk by using screening tools such as the SOAP-R, which is a very easy screening tool. You have the website here that provides it. And for low-risk patients, maybe once, max twice a year. Moderate to high-risk patients more frequently. And that's typically kind of the standard of care for pain management. So it's the SOAP-R is a pretty easy test to do when you start prescribing opiates and to assess risk. It should probably be repeated every once in a while just to make sure that the risk hasn't changed. Again, random drug testing at variable intervals is best, but sometimes it's not feasible in most practices. There's also cause-based testing. So someone who's getting early refills, reporting lost or stolen prescriptions, drug overdoses, they present to the emergency with a drug overdose. These are patients that probably should have drug tests for a cause. If they appear intoxicated when you see them, or if you get calls from family members saying, hey, your patient so-and-so is selling their prescriptions, those are times you should probably test. Immunoassay is what you basically get. The one that says positive or negative, that's an immunoassay screen. That's basically a biochemical test. It measures the presence of a molecule, and the molecule is very specific. So it may be, for example, morphine for the opiate assay. It may be oxazepam for the benzodiazepine assay. So you're measuring the presence of a specific molecule, and therefore these tests are very sensitive typically, but not very specific. In other words, they will capture use, but it will not be specific enough to tell you if that's a false positive test. So the false positive rate for the immunoassay tends to be high. the false negative rates tend to be very low. And you can change those by kind of setting the cutoff values differently. So you have to really know what your lab is doing to determine the sensitivity and specificity. But in general, you're going to have a high sensitivity and a low specificity, which means the false positive rates are very high or can be very high. The use of an immunoassay does not distinguish among individual substances. This is important. So when you see someone that tests positive for opiates, it doesn't tell you what opiate, whether it's morphine, heroin, codeine, or hydrocodone. It really doesn't tell you what substance is in their urine. It just tells you they tested positive for opiates. It's also important to remember that the opiate, the one that says opiate on the immunoassay, is testing for morphine, which means that you're going to miss any of the synthetic opiates such as fentanyl, methadone, buprenorphine, oxymorphone. These will not be positive on the opiate immunoassay. Hydrocodone does cross-react, although some individuals it can be negative. So this is the one caveat to not testing for negatives, and I'll explain that in a minute. The benzodiazepine assay also tests for different, it depends on which metabolite you test for, whether the detection will occur. So depending on which benzodiazepine you're looking for, the sensitivity and specificity for some specific benzos like clonazepam will change. So you have to know your drug test. Amphetamines, this is the highest false positive rate is in this assay, primarily because of over-the-counter decongestants such as pseudoephedrine and phentermine. Positive abnormal test results require confirmation in general, especially if the patient is not admitting to use in a setting such as pain management or addiction management. Now, if I get a patient that comes into me and says, "Doc, I relapsed over the weekend, I used heroin and cocaine, their urine drug test comes back positive for opiates and cocaine, am I going to send that for confirmation?" No, because they already told me they used, so why would I confirm it? I don't need to. What I tell providers is, for primary care docs who know what a D-dimer is, this is no different than a D-dimer when we screen for DVT or PE. A positive D-dimer doesn't tell us too much. A negative D-dimer in someone who's at low to moderate risk for a clot tells us that we don't have to do anything else. And this is the same with this urine screening test. A negative test means we're pretty much done. A positive test means we may have some more work to do if the patient's not telling us that they use. Again, the false negative rate is typically very low within the window of detection. It's inexpensive, the immunoassay, that's why we use it. Rapid turnaround time, it's widely available, and it's non-invasive when you use a urine. The limitations, again, the false positive rate tends to be very high, and you have to understand the sensitivity of each assay for the substance of interest, and that's extremely important. Some people will call a negative opiate on someone with oxycodone a false negative. That's not true. It's not a false negative. It's a true negative because you're not testing for oxycodone. So you have to really understand the test itself before you start labeling things false positive or negative. And urine, obviously we know this. Anyone in addiction medicine knows this very well, that it's very susceptible to sample adulteration. So clinical pearls quickly regarding urine drug testing. The important thing to remember is an abnormal positive test result that you don't expect does not diagnose substance abuse or addiction. Substance use or addiction is a clinical diagnosis. The testing may help support your diagnosis, but it does not diagnose a disease. A negative test result does not guarantee that a patient does not suffer from substance use or addiction. So if you have a clinical history that's consistent with substance use disorder, just because they test negative doesn't mean that they don't have a substance use disorder. Positive random urine drug screen. So if I test 100 people in the general population and 2 of them come back positive for cocaine, and I ask them about it and they tell me, well, this is the first time ever I've used cocaine, chances are that that's not accurate. Random urine drug tests are most indicative of regular, not sporadic use, and there's pretty good data on that. I mean, if you think about it from a probabilistic standpoint, if I test someone once in their entire life and they come back positive for cocaine, what are the chances in the entire life that I would have captured the one use? Pretty small. In pain management and addiction medicine, all positive urine immunoassays should probably be sent for confirmatory testing unless the clinical situation is such that you don't need to. For example, the patient's admitting to use, or the patient is stating that, or after the fact admits to use. So they may not admit to it before you do the immunoassay, but you get the immunoassay back and you say, hey, your drug test came back positive for cocaine. You want to talk to me about it? And then they go, yeah, I didn't think it would come back. It's been like 3 or 4 days. I didn't want you to find out. A lot of times these patients will admit to it after the fact when it comes back positive. You may need to request additional confirmation for things that you didn't test for after the fact if you're concerned, for example, the fentanyl, buprenorphine, or methadone. As a general rule, negative drug tests do not need to be sent for confirmation. Always, and this is a good rule of thumb when you do this test, always ask the patient beforehand what you expect to find in the urine prior to testing. A good patient history is still the key to patient rapport. I always ask my patients, what's going to be in this drug test? What am I going to find? And you'd be surprised. They tend to be more honest than you would expect. And develop a protocol. This is extremely important. Make sure you have a protocol about how you're going to respond to the drug test results. It's important that you think about this beforehand, because once you have the results, you have to act on them, just like any other test. I mean, if you're not going to do anything about the test results, why are we getting the test in the first place? Always remain empathetic, but demonstrate tough love with patients who do not comply with treatment. That does not mean terminating them. That means making sure that they're getting the appropriate care that they need. It may mean increasing the level of care. And that's pretty much my really rapid presentation on urine drug testing.
Hey, thanks so much for bringing that for us, David. Really appreciate it.